Welcome to this first plenary session of Rhythm Interventions Online 2025. We've got a great session in store. A live case from Domenico Della Rocca and Antonio Sorgente from the University Hospital, Brussels. But before we join our case center, I'm delighted to welcome our fantastic panel. We're joined by Serge Boveda from Toulouse, Claire Martin from Cambridge, and Christian Sohns from Oeynhausen. We're live and interactive, so get involved by submitting questions to the faculty in the webpage, and we'll address as many of them as we can. Before we hand over the case center, we have an audience poll pertinent to this case, so please get ready to vote on the webpage. The question is, what's the best case scenario for choosing Fairview to perform an AFib ablation? A 45-year-old male with paroxysmal AF and normal left atrial dimensions. B, a 72-year-old male with early persistent AF and a left atrial AP diameter of 45 millimeter. A 65-year-old female with atypical atrial flutter after PVI, or an 80-year-old male with long-standing persistent AF, a 60 millimeter left atrial diameter, and a prior CTI flutter. Please vote now, and we'll look at the results shortly. All right, let's now join our case center. I just want to remind everyone to please submit questions as we move along. Domenico, welcome to RIO.
Yes.
Can you hear us?
Hello, Devi. How are you? Yes, very well.
Hello, everyone.
All right, wonderful. Hello, Antonio. Welcome to RIO, and you guys are kickstarting our first plenary session. All right.
Perfect. So,
take it on.
Yes, so thank you very much for the invitation, and hello also to Serge, Claire, and Christian. Before talking about the case, I would like to introduce the team here. So I have Dr. Sorgente with me and our fellow from Romania, Paul Calburian. I have our staff nurse, Anna Omen, and then like our head nurse, Donna Berisha, and also the support for anesthesia is Professor Becker. And so like I have here also all our fellows, you know, this is like a very active university hospital. So we have a lot of support and also a lot of activities going on, but we can move to the case, and Dr. Sorgente will introduce the patient of today.
Yes, so we are performing this ablation on an 80-year-old male with hypertension, diabetes, and a previous prostatectomy. So he has been in persistent AF with since a few months, and the first episode was documented in February this year. He got in another center a electrical cardioversion. After that, he got a recurrence on the month of August, and then unfortunately, starting developing a worsening dyspnea and worsening left ventricular ejection fraction. So to wait for the procedure, actually, we performed in October a cardioversion, and today the patient is in atrial fibrillation again. So he has a mild to moderate mitral regurgitation, and the volume of the left atrium is quite dilated with 43 millimeters per square meter.
Okay, perfect. So now as you see the screens, we are already transeptal, so we are ready to start them up. I'm gonna use a FARAVIEW today and the 31 millimeter FARAWAVE catheter, FARAWAVE nav catheter. And so there are different ways to map, and I would like to show you like what we do. And this basically
Domenico,
try to keep the volume.
Can we have your team? Domenico, can we have your team change it to the lab? Yeah, there you go. Wonderful. Thank you very much.
Okay, perfect. Okay, so yes, so you see like on fluoro, we have done like transeptal and we are ready to map. And so there are several ways.
We just have you on camera right now, Domenico. Domenico, we just have you on camera. We don't have you on the fluoro. Oh yeah, now we do. Wonderful. Thank you. Keep going.
Yes. Okay. So like everyone has a different approach to mapping the veins, and so I would like to show a workflow that we put together here. And so like what we would do like generally is like going inside the vein, and so you see also the mapping system, right?
Yes,
Devi,
we do.
do you see the mapping system, correct?
Yeah, we see the mapping system.
Yes.
Okay, so that's better.
Okay. So like a classic approach would be to like close the. So first of all, I would like to say that we don't do CT scan anymore, and we don't do that because with FaraView we really have we have a good understanding of the anatomy, and we have learned a lot also from our fluoro only approach and adapted the fluoro only approach to what we learned with FaraView. But so one approach to map the veins would be to get inside the vein, and then last week and I would like also to introduce the Opal system, Lars Lowy, and Nikos Tsirimokos that are here to support the case with us. And so I'm starting now sampling the vein, and then one common approach would be to open in basket here when I'm outside, and then acquire here the antrum of the vein. But this frequently ends up being getting a lot of more volume, and so it's hard to understand really the coaxiality and the coverage of the antrum of the vein. So with that said, we can erase what we have done, and I would like to show you what we do with our we adapted a little bit the strategy. And so from here we do we start mapping the vein, so we can start mapping and get some anatomy of the vein. Okay, acquire.
Serge, let me bring you in.
I asked
as Domenico is doing his map. This is looks like an early persistent kind of population. And, obviously the FaraVave the Opal system is a great mapping system, but it definitely is not a high density mapping catheter. So what are your thoughts on substrate mapping in a case like this? And Domenico, keep going.
Yes. Devi,
Yes.
before, if I can, I just wanted to show you this part of the vein, and then I keep going with the map. But I wanted to show what we do with. So when I'm inside the vein, I ask for to go off mapping, and then on fluoro I check when the catheter jumps out of the antrum, and then I ask for a tagging of the equatorial tagging. So we tag the third electrode on the map so that we know where the edge between the left atrium and the antrum and the ostium of the vein is. And this way we keep the volume as limited as possible in order to understand the anatomy of the vein. So with that said, I let Serge answer the question, sorry. So Lars, we can...
Thank you very much. Thank you, Domenico. Yes, about the substrate mapping, it's true that the system, even if it's not a high density mapping, works quite well for the voltage map. And I think that it's sometimes interesting to see what is the voltage, especially of the posterior wall, for example, but also of the antrum. So yes, I think that it can provide some information about the disease of the left atrium, even if, again, I insist, it's not a high density map, of course.
Okay, quite here.
Are you using on the regular basis yourself?
In this context, just one question. You now have the patient in FIB, and why you map in FIB when you look for voltage instead of doing a cardioversion to sinus rhythm, or do you do this after the pulmonary vein isolation? Any comments?
So I'm not gonna look for voltage here. We are mapping, we are getting a voltage map, but I'm not interested in voltage. At this point, what I do, I go for veins and posterior wall and then cardiovert at the end. So voltage is not, I'm not interested in voltage. I'm more interested in getting a nice anatomical understanding of the distribution of the veins in order to have a nice coverage on the anteposterior wall. And then I will cardiovert at the end. So I could have cardioverted now and have also a substrate understanding of the substrate, but we can start now with FIB and then see. Sometimes we have also some experience with high density mapping with Opal, and this tool, this mapping feature that is called OCAM that we used a lot with FARA and with Orion. And so we try to target also some areas that we see that are recurrent in patients with AFib. So now I'm gonna see the jump of the right superior, And so here I see that it comes out. So I ask to tag the level of the antrum. And then from here, I move down to, 1 second. Okay.
Yeah, I was just going to say, I mean,
a question on imaging. So I was going to say, Domenico
Yes.
said that they don't do imaging or CT anymore.
Right, please.
You know, in the US, we're very used to using intracardiac echo to see how many veins and et cetera. So are you doing PV angiograms then to assess just the general anatomy, or are we doing just fluoroscopy? And Claire, I'll let you jump in and kind of talk about your workflow.
Sorry, yeah, well, just to answer the first question first about whether you need a high-density mapping catheter or not, I think that entirely depends on what your strategy for the case is going to be overall. And Domenico here is basically using it as an anatomical-based strategy, and therefore he doesn't really need a high-density mapping catheter. I think that if you're trying to do like a complex redo atypical flutter, then that's when using the Orion catheter would come into its own. But now, yes, to answer your question about imaging, yes. So in my center, we do CT scans in advance of all cases, and I think you can question whether that's really necessary or not. I think one of the issues is that in our center we have a very wide variety of different techniques, and often we don't know which technique is, which operator the patient's going to be listed under, and therefore which technique the patient's going to have done. So when booking the case, it is easier to book a CT scan, because I think that is quite useful for example, cryo when you don't have any mapping. I think when you do have 3D mapping, it becomes less useful to do a CT scan beforehand.
If I can say something about that, I mean, we are also, speaking about a procedure or a technology that can increase the risk of renal insufficiency. And so, I mean, having said that, we didn't have so many cases of acute kidneys failure after PFA. I would say that the CT scan would add another possible, motivation, to get acute kidney failure. So I think, I mean, of course, for anatomy purposes, this is a great possibility to get an idea of the anatomy before the procedure. But I mean, I think this workflow works very well in our experience. I would say also that with FARAVIEW we got a lot of this chance to get these additional veins on the right side, and Domenico has work on this purpose, right?
Yes, and so yes, as Antonio was saying, like if you take like a few minutes, we are talking about like 3 to 5 minutes more to wire, get inside the vein and understand the distribution of the veins, then you always, because it's interesting to see that so frequently if you look at fluoro only, you think to be in the same vein, and actually like the orientation is different, and there is a separate vein, especially if we are talking about the right superior and the right mid. And so I think with FARAVIEW, we really, it's very, very hard to miss anything like that. And for sure, like as Devi, as you said, like ICE is an incredible tool. But I think for me, like if I have like a nice delineation of the veins and I understand where I'm landing with ablation, I really like having a mapping that is, although like it's not perfectly accurate, especially in terms of substrate, but gives me a good understanding of where I'm landing with the catheter. If I may show you something now. So like now, as you see, we went inside the main branches and we tagged this antral part. So now we are in the left superior. And so what I'm gonna do is just like ask to acquire without going beyond this point that we tagged. So that point is our level of antral level. And so now what we do, we start mapping, and this part is very fast, and we go around, and then we move to the inferior, and then we go there. Please advance. Full back and advance, yes. Yes, and then from here I always keep in mind that I don't want to go beyond, because I don't want to acquire too much volume that would make my understanding of the distribution of the lesions complicated. Another thing that I do, I keep the size of the field tag a little smaller. So instead of 6, that is 6 millimeter, that was suggested, I go for 5, because I also have a good understanding of possible gaps in the distribution of lesions. But then like we can skip this part. So like from now I can quickly map the posterior wall. I don't need any, I don't need much fluoro here. And so I keep going and I map. And then when I get close to the right veins, I stop mapping and I go back to this mapping on and off to avoid this excessive volume when I acquire the veins. But so what we can do now, we can skip this part, and we already have like a map that we acquired before at the beginning. So as I said, like what's interesting is just like the anatomy at this point. And so we go get the superior vein. Yes. Yeah, you can put back once there is another branch superior, that's fine. Okay, and so like I try to align myself to the vein. Second, yes, okay. And so I try to stay coaxial. So the patient is in fib. I don't know what is your practice for vagal reactions, but we find it very useful to give to pre-medicate with Robinul, and I have also some a slide that I would like to show just to understand, like because I saw we published a few months ago, and there is also a recent paper with showing that atropine gives like a lot of urinary retention. That is a complication that we know, but the advantage of using Robinul is that the rate of urinary retention is much lower. And also another thing that can happen is that the atropine cross the blood-brain barrier and can give some neurological symptoms, like even in some cases delirium. We had like one case like last year before we started using systematically Robinul, and this is something that doesn't happen with Robinul. So I don't know what is your practice if you pre-medicate the patient, atropine, Robinul. We also described this right superior pulmonary vein first approach to stimulate the ganglion in order to get a little bit of tachycardia from the patient and avoid these vagal reactions. So maybe like in the meantime, I will start with ablation.
Yeah, go. I mean, yeah. So I think I'm going to run back to my panelists too. So, but we do have a practice of pre-medicating. I do see that you have a CS catheter. So usually if you have a pacing catheter, we'll just pace, or if there's a pacer. But our practice has changed where, I don't use fluoroscopy, so I don't have a CS catheter in place. In that case, we actually use Robinul. Serge, Christian, and Claire, what are your practices?
Fantastic.
Well, if I could answer that, I mean, I was wondering, because you do have a catheter there. We don't pre-medicate because we use a diagnostic catheter to help with the transeptal puncture, in which case we just put that in the RV and pace if we need to. So I wonder, why are you using any medication when you have a catheter there anyway?
So for generally, it's like we frequently do like especially for PVI only, we do like without the CS catheter. So in this case, and also the patient in sinus is the one that is more prone to having this vagal reaction. So in this case, we like pre-medicating because we don't have the backup of pacing. So that's why.
I mean, we also used pacing leads before when we had the first clinical experience with the device. We also had an RV catheter in place. We always have CS in place now, also to guide the transeptal puncture. But I think also something we use very common is atropine. But in Germany also there's a difference because we do all these cases in cautious sedation. So the patients are not intubated. They have a kind of, let's say, sedation with propofol, and that works pretty good. And we use the same medication approach, which is guided by nurses, irrespective of the PFA device we use. So also for Afera, variables, fair enough. And it's always the same approach and it works pretty good.
I'm
In
just
France,
curious
you don't
if
have
I
the
can ask.
option.
Sorry.
Yes. So I was saying that in France we use just the atropine in case we have a bradycardia, but we have also the catheter to pay. So we usually don't give it systematically. We just give it on demand if needed, atropine.
So, Domenico, I see
So
that
here
you're
I'm
doing
giving,
some anterior lesions there. So that's
yes,
you're doing a
yes.
more segmental approach. Yeah, that's
Yes, so I follow like the first two that are quite, so now I'm doing like for each vein, there is like, I try to cover some weak points that like based on the literature, we know that are the areas where we have a higher likelihood of reconnection. So we know, and you have like a big experience with eyes. So sometimes with fluoro, we don't appreciate that we might sit very proximal on the posterolateral ridge and don't have a good depth on the superior anterior part of the right of the left superior. So what I do is like a counterclock rotation of the sheath and also counterclock rotation of the catheter in order to sit anteriorly with some splines and cover this area that is on the roof anterior that is that gives reconnection. And now I'm giving the second bonus application that is from the superior side of the carina between the two veins. So we can give two more applications.
I have a question for
Just
you.
in terms of this ablation approach, maybe Domenico, one question from me. From redo ablation procedures, did you adopt your ablation approach to what you find in terms of gaps after a first approach, a learning curve effect or something like that? What can you comment on that?
Yes, so that's a very good point, and this is like we learned a lot by remapping these patients, and I think either like acutely and also like patients coming back, and so like based either literature and what we see reduce, we adapted like this is like an active learning. So every time we learn that, but there is this patterns that we learned, and that's why we adapted our ablation approach based on what we see reduce. Yes, absolutely.
so. Domenico, let me
And
ask you a question.
So-
I see that you.
For the since you are using the far view, Domenico, do you think that you are using less application than without the far view, or the same number of application, or more, less? What is your impression about that?
Yes, this is interesting because we thought we had quite a consolidated ablation strategy with fluoro, so we were not expecting big differences with FARAVIEW. But then, like as you said, like what we notice is that we have like a 15 to 20% reduction in number of applications. We gave two here, right? So and so I think it's like for sure like having a better understanding of like a better tracking of the catheter helps us reducing the applications, especially for the posterior wall, because you will see for the posterior wall we tend to do like a 3-line approach, including the roof, and I think with the FARAVIEW we reduce significantly the number of applications. I want to show you something here. So if you see, basically with this tagging system that we use, we never shaved. So so it's basically you can really see, you see the gaps, you see where you land with the catheter. You can, and here I can use very few fluoro to do that, and also like I understand where I have to cover in terms of field tags.
So I think that's a
Can I
great
make a
point,
question
Domenico,
just
that,
for-
yeah, you have the field tags at 5 millimeters, so it's a very conservative approach. So, which is good because I think the system asks for a 7 millimeter tag, so I think we use a 5 millimeter tag as well. I'm just curious on your workflow. I saw that you started with the flower. Are you gonna use basket applications in the left superior? I saw that you had some basket applications in the inferior. Do you do olive leaf?
No, I did. I did also basket. Yes, I did. The first applications were in basket.
How about olive lesions? You do
basket
deep lesions?
No, I don't do olive because I think the problem is like good coverage of the antrum. So I think if I take care of the antrum well, and the way I do it is like this. Now you saw like before these applications, I gave a bonus at the inferior posterior segment of the left, and now I'm trying to cover a little bit more. So I'm counterclocking the sheath, and I'm covering the ridge here. So I'm more anterior to application. If I give like the classic 4 applications in basket, and then with flower I cover nicely around the end, the antra, I don't have a feeling that we have big problems of PVD connection with that. So I don't do the olive. I don't want to.
And the other thing with the olive, I would say that we don't want to risk to deform the catheter. Sometimes, I mean, with putting for the olive the catheter inside the vein, we can have like a deformation of the catheter, and then can be difficult to continue to perform a nice ablation in the other veins. So we don't routinely do that. But if I can add just a question for the colleague that is using a sedation, I want to just because we use routinely general anesthesia. What is the experience of patients doing this procedure in sedation?
Yeah, I mean, this is difficult to judge. We asked the patients, and we published this just for the variables, for example, would you choose the same sedation protocol if you have a repeat ablation procedure? And so more than 90% of the patients said, yes, I would go for the same approach. On the other hand, they do not know any other approach, so it's difficult to judge. But from a patient perspective, or let's say patient-reported outcome, they are very happy, and they would choose the same method again.
Okay, thanks.
So now we have done the 4 applications in basket for the right superior, and then like this is the first flower, and then we do the second flower for the right superior. As we see from like a literature, like so the weakest spot is anteriorly to the right superior. So either I try to cover that part, and as you can see here also the coverage of the anterior segment of the right superior. Maybe Lars, you can align, show the septal side, and then align the veins, please. Align the veins. And then so you see that is a little bit like we have more posterior coverage than anterior coverage. So what I do, and I will do it at the end, is if I cannot reach anterior, I can try here. Yeah, I can reach nicely here. So I will give another application here to have a better coverage of this, the septal anterior septal side of the right superior. But otherwise, I do like an application, especially for very dilated atria. Sometimes you cannot reach the anterior side, so I do a rotation from the anterior part, and I land on the anterior side of the right superior. Okay, let's pull back and advance.
Domenico, while you complete the right veins, let me bring up the poll question and the answers. Our audience have been participating in the poll. So while you complete the right veins, let's take a look at the poll. So for the question asking, where would you choose Fairview? It looks like we have almost even split between a paroxysmal AF patient with normal atrial dimension and a 72-year-old with persistent AF with a dimension of about 45. So Serge, let me just jump in and ask you, what are your thoughts on our audience response here? Is that what's aligned with your practice, or?
I would have answered the second patient, so the 70-year-old male, because yes, it's true that the Fairview can do definitely PV isolation. So for a paroxysmal patient, that's for sure a good tool and a good indication. However, I think that for the second one, it has the possibility to do PVI plus lesions. And I think that in this case, it's interesting. For the third and the fourth one, I agree with the attendees that probably for the third one, I would go more for a high density mapping system. And for the fifth one, maybe I would even ask if the indication of ablation is the right one, because in this case, I think that the chances of success are very little. So I agree generally with the answers, but my favorite would have been the second. But I am interested to know what thinks my colleagues here.
Yeah, Claire, what are your thoughts?
Yeah, I think in general, I agree with you, Serge. I mean, I also think that Farapulse is a very good technique for just doing PVI, and I would use it for patients with paroxysmal AF. But I guess what sets it above, for example, cryo, means that you can do a lesion set outside the PV, but I guess then you're mainly basing it on doing posterior wall isolation, and then it really depends whether you feel that posterior wall isolation is going to make a difference. I think that's quite a controversial topic, I guess. There's no strong evidence that doing a posterior wall isolation will necessarily help, but at the end of the day, if you want to do something, then it's a reasonable thing to do.
Okay, that's the lowest. Okay.
Christian, let me ask you
I
a
think it's
question on
important
the
also
whole
to
mapping
mention or to
situation.
acknowledge. I think it's also important to acknowledge
go ahead.
that we can use FerroView for all these different scenarios. We can use it in paroxysmal and persistent in patients for repeat ablation procedures, and even in patients who have atypical flutter. We can use it, and we can always show that we have good results using the technology. If it's just, and sometimes you cannot change. I mean, you schedule a patient for a certain kind of procedure, and after you isolate the veins, there is tachycardia. After you isolate the veins, there's some other things that occur, or you see low voltage areas. And I think that's the real benefit, that you are no longer dependent of a system. You can do all the procedures with the system. And I think this is a big benefit.
Yes.
And this is why I will go for A, B, C, and D.
Yeah,
I'm interested to know whether the rest of the panel use the Farrow. Do you use the Farrow wave catheter to do linear lesions? Like, do you use it for mitral isthmuses and CTI lines? Because currently I do not, but I'm interested in if other people do, whether they use that with nitrates, etc.
I mean, it's a great question, right, Claire? I think the point is it's a very versatile system, but I mean, if the patient develops a tachycardia in between the case, you're not going to more than likely pull out another catheter. I mean, there's the cost aspect to it, but I think there's enough and more data now that, you know, there's some durability concerns with using the system in for linear lesions, especially the mitral isthmus. So I do think that we have to keep that in mind as we take this outside of what it's designed for and start using it, you know, in areas like mitral isthmus. I think we have to gather data on best practices and maybe look at other options. Domenico, I'm going to let you kind of jump in and tell us where you are, and then maybe take a stab at that question that Claire had.
Yes, so first of all, I want to say that so one other point that is a kind of like limited coverage that we always that we notice always is the inferior posterior segment of the right inferior. And so what I do in addition to the application, so I try from here to go to the carina on the superior from the inferior and from the superior, from the right superior. But then another application that I do is either I'm with FarAview and I can track, but if I have fluoro only, is like bending the sheath and then posteriorizing and pulling down. And this way I cover better, like have good contact on the inferior part of the right inferior. And this is like always a bonus application. But as you can see around here, so can we show the septum? So we cover the septum, we cover the anterior part of the right superior, and so we are ready to go to the posterior wall. So going back to the question of Claire, so we have done, especially the earliest point of our experience, some posterior mitral lines, and it's tricky because it's like you can block the posterior mitral line, but then but then the durability itself is quite limited. So acutely, you need to give a lot of applications plus like nitrates, and chronically is like the reconnection rate is very low. So maybe we have like a experience that is under review with Serge, and this is like a little bit of our experience. We also have some experience with acute mapping and chronic mapping of the posterior mitral line, and also the posterior box with endoepi with our surgeon, because frequently we work with our surgeon for hybrid procedures. And so we like ablating endocardially and then see what happens epicardially. And the posterior mitral line is like a very limited transmurality, unlike the posterior wall that is where we have like a 100% transmurality acutely, and in the remapping phase in patients that we saw for different flutters, we have also 100% durability. But I have to say that we changed a little bit the workflow, and so at the beginning we started with a limited overlap between applications and through 2 lines, and now what we do, we try to have a more roof line and go from the roof line to the superiorly, and then give 2 applications between the superior veins. So right now I'm trying to get to the roof, and like you see, what I see here is basically some splines, the anterior splines, so basically C and D when I see B, that when I see on fluoro that are pointing towards me, and some splines that are going inferiorly, the posterior splines that are going inferiorly, and at my level of the roof. I don't want to go too anterior, because then if I have an anterior scar and I make a too wide box, even covering anterior the roof, I have like the likelihood of having like anterior reentry or like a perimitral flutter is much higher. So we can start with 2 applications here. So we start anchoring with the lesions of the left superior, and then we keep 50% overlap between applications. And so we will do 1 roof line, 1 superior to superior, and 1 inferior to inferior.
Domenico,
So
it's a really nice, elegant way of having a very focused approach. I like how you took the right veins, and it's almost very segmental, targeting the areas that are usually considered to be areas of high reconnection, and especially when we have seen some of those remapping data. So a really elegant way of kind of using the mapping system to kind of guide where the lesions have to go. While we have our panelists on, let me ask a little bit about adoption of PFA, and I feel like this is one of those technologies that has taken the world by surprise, especially the EP world, how quickly we adopted this technology into our practices. And there's obviously, I mean, we have safety that has brought this along, right? We think this is safer, but it's definitely opened up a Pandora's box of new things, such as hemolysis and spasm. So, Serge, let me ask you about spasm. But to me, I think this is one of those, I almost feel like it is the new esophageal fistula of the PFA world. It's rare, but when it happens, it's bothersome, right? We worry about it. What's your experience being with spasm? I know Domenico talked about nitro when you're by the AV analyst, but how about generalized spasm when you're not by the AV analyst? And what are your thoughts about mechanisms?
Yeah. So the second part of the question is very difficult to answer. So I will start with the first part of the question. The spasm we had, honestly, we had quite, I would not say often, but we had many spasms at the beginning of the experience, because we were doing, like Domenico was explaining, quite often mitral lines. And in this case, we had, and this has been the publication that we have made in the JACC-EP in 2022, we had about 12% of spasm in the mitral isthmus. So spasm, it's not rare when you are going out of the veins, and especially in the right isthmus or in the left isthmus, in the mitral isthmus. Now we don't have, never, because we have stopped doing mitral isthmus, because as Domenico was saying, there are a lot of recurrences, and this is also a paper that we have published on that, with nearly 80% of recurrences of the mitral after 1.5 years. So basically, it's true that when we started with the protocol of nitro, the risk of spasm decreased a lot. I mean clinical spasm, because there is a question about what is really a spasm. Is it only clinical, or is it infraclinical? It can be also infraclinical, and we don't know about that. So this is why I would be very, very cautious to say that you have no risk if you use nitro for the spasm. My advice for the moment would be not to go for the mitral isthmus because, as we were saying, the risk of recurrence is so much. And about the mechanisms for me, the mechanism of spasm for me, it's difficult to explain now. I would think that it's more a kind of a barotraumatism of the coronary arteries. You were comparing the spasm with a fistula. I would not go this way because a fistula, as we know, is very often a little complication, and the risk of death is very, very high. With a spasm, if you act at the right time with nitrates, sometimes intracoronary nitrates, the patient is doing well after the resolution. So, and it's a transitory complication, it's not a definitive complication. However, again, I would remain very cautious, and what we are doing in my center now is to go to the mitral in very rare cases. For example, when we have a mitral flutter that is occurring during a posterior wall ablation like Domenico is doing now. If, for example, now the patient was going in a mitral flutter, then in this case, maybe we would go to the mitral isthmus, but never systematically.
I think that's a great point, right? You have a good catheter that is designed for PV, and maybe the posterior wall, like Domenico is showing him, he's doing a very elegant posterior wall ablation there. I think it's important that we use the catheter for it's designed for, but keep in mind when we take it outside of these areas, what the implications are. Christian, let me ask you a question on hemolysis. Are you doing any particular, are you hydrating the patients at your center routinely? How are you managing the risk for hemolysis with these large footprint catheters?
Yeah, I think that hemolysis is more or less an effect of the so-called ablate-like hell syndrome, which we observed in different centers that we ablate everywhere and do more than 100 and I don't know, many applications. So our approach to avoid it is that we stick to what is in our view necessary for the patient. So we do PVI. Then we map the patients and look for low voltage areas, and only if there are additional targets we ablate it. So I think with sticking to the standards and doing the applications which are recommended, you can already avoid these side effects like hemolysis. If it's necessary to do more applications like that, we check the patients the next days, but we have no systematic approach to avoid hemolysis.
Lars.
Yeah, I would agree that if you keep to a reasonable number of lesions, then that shouldn't be a problem. We have not had any cases of clinical hemolysis. The other thing is that there's evidence that if you have good contact with the tissue, then you will also limit the hemolysis. It's more of a problem when you have bad contact and the tissue and the catheter is in the blood pool and therefore hemolyzing the blood cells. So it's not something that we've had a clinical issue with.
I agree with
Domenico,
I think the far view may be another way to decrease hemolysis, because the far view is probably providing a better contact of the catheter with the tissue. So I think that this is also a point that should decrease the risk of hemolysis, apart from the fact, as Christian was saying, that we shouldn't ablate and give too much application. That's the main point.
Yeah, I think it's good that we have these new mapping systems now, right? Especially with these lesion tags, like Domenico was saying. It was surprising when we actually moved to the system, how, and we have systematic data that showed that we have less number of applications than when we were just doing catheter shadow overlap instead of using just lesion lesion tags. So there might be, value in integrating these mapping systems, because it does help cut down the number of lesions too. Gives you a sense of confidence. Domenico, I want to bring it back to you and Antonio. I see that you guys are doing post-map, and walk us through the final steps as we...
Yes, so we are now checking the post-map, and like it seems that everything is we are avoiding to cardiovert now, and we will cardiovert again. We will cardiovert later because like we want to keep the position and understand. But we will also view have a look at the lesion tags to see if there are some weak points that that we missed. Because one thing that we need to keep in mind is that we cannot rely on a signal elimination for PFA, and so we want to also see that like anatomically, like in terms of distributional lesions, we have everything covered. I would like to add something for in terms of for hemolysis. Yes, for hemolysis, because it's like what Claire said is an extremely good point. So basically, like if we see the paper of Jakob Korut on a number of applications and contact, you can really see that like if you don't have contact, the amount of hemolysis goes very fast, very quickly up. But if you have good contact, then like you keep your amount of hemolysis even with like an adding amount of applications quite relatively low. So there is still a risk, but I think is like the most important point to avoid hemolysis, to avoid acute kidney injury due to hemolysis that like is contact. So we will be ready to cardiovert a bit. Yeah.
Can I ask you, Domenico, do you
low.
always do
Okay.
acute
Yes.
remapping? Is that something that you find useful? Because generally you get what you get there, which is just no signal at all. So do you find it clinically helpful?
Absolutely. So no, absolutely. So this is but what we find more useful is like maybe Lars can show the lesion tags. The most important thing and what we really look at is like the distribution of the lesions. So we go around, we really take our time to, and also now the patient is in fib, so very low potentials. But let's have a look at the map. Do you see the map on your screens? And so we go around and see if there is so we cover the septal area, and then the roof, the anterior part of the vein, and then we have also the anterior part of the left superior. We have this tree line, and then also you see these anterior lesions that are on the posterolateral ridge. And so at this point, we are ready to cardiovert, and absolutely agree with you that since we don't have like that important feedback, unless there is a vein that is missed, and then there is no real need for remapping.
So go for
Maybe
cardioversion.
may I
So
ask
we
you one more
cardiovert
question
now.
before you do, or even after cardioversion? How good is, to your experience, the match between the field tags and the low voltage areas after the ablation? I don't know if you can show us data, but what is your experience with that?
With the distribution of field tags. So I think if we keep the volume as limited as possible, you really have like a good understanding of like field tags do a good job. So if there is and so I think we find this way like a very useful way to understand that there is a good correlation between field tags and the low voltage, like isolation areas, and but then if there is pushing, or like we use a basket for the antra to acquire the antra, then also the anatomy is not that reliable. So I think if we want to do something, I mean, then the beautiful thing of this technology is that it's efficient and effective, efficient, and safe. And so we have like a combination, a very good combination of things. We want to be safe for sure. We want to be efficient, and but we also we want to be effective, but we also to keep the efficiency. So if we take like 45 minutes for a map, this doesn't make sense anymore. But I still I think, especially for the vein, if we can spend 5 minutes more to do that, I think it's useful. And but then if there is like a time constraints, like the lab sometimes is I think like also the ablation and mapping and ablation, like there are many combinations that you can use, but they are all of them quite reliable. I think for an operator who's starting and has like limited experience with the catheter, I would say like taking 5 minutes more for the map is important. So the patient is in sinus now. We cardioverted and we gave 70 applications.
Domenico,
The
I
other
want
thing I
to
would add,
thank you
Domenico,
and
just one thing about the learning curve that is absolutely a very short learning curve here in our lab. Here we actually are letting all the fellows doing the procedure with our support, and this actually is a great thing. I mean that this technique can be standardized and becoming really more like a standardized therapy.
Yes.
all right. Well, thank you, Domenico and Antonio, for an elegant presentation
Thank you.
elegant
you.
case of PVA and posterior wall. And thank you to your team to joining us for our Rhythm Interventions first session. And thank you to our panelists, Serge, Claire, and Christian, as well, for having such an engaging discussion, and to our audience. Up next is an ablation case live from Paris. For that, I'm going to hand you over to RIO's founding course director, Richard Schilling, in our London studio. Stay with us.